And thanks for having me, guys. So I love Randy Brown. I'm going to tell you guys, I am no Randy Brown. Dr. Randy Brown has been a dear friend of mine for about 20 years while I've been in the allergy and asthma space. He is the guru of all things chronic disease management. He actually sits on the board of directors at Allergy and Asthma Network, so I'm very blessed to know Randy well. He and I tag teamed on this Wizard of Oz paradox presentation one time several years back, and so when I got the call at 10:30 last night, as I was walking out of a show on Broadway in New York without a gown, I said, of course, I'll be happy to step in and do the best job I possibly can. Went and found a gown, all was great, got a flight, everything was on, just working exactly as it should, until the storms hit Charlotte today. And then we were circling and circling and circling, sitting on the tarmac, and it was a crazy afternoon. I was supposed to be in at 4, didn't arrive till 6:30, and no bag, no gown that was purchased today. So here you get me, and you actually just get Dr. O'Connor, who just walked in the room, as she was delayed in flight as well. So crazy day. Crazy day, but we're here, and we're here to really advocate and to really get energized by this evening, because as Lauren said at the outset, we have a lot of different people in the room. I'd like to kind of start off by saying, how many of you in the room are providers? You're a healthcare provider, either a physician, a family nurse practitioner, a nurse? A few hands. Okay, looks like maybe 15-20% of the room. How about those of you in the room who are patients? Patient advocates, pretty much, even if it's not primary immunodeficiency, PID, all of us are patients in one way or another, probably, right? Or a caregiver if someone you love has the disease and you're living and supporting them. Great. And then how about those of you who work in the industry and support patients and families and providers who are in this space? How about industry folks in the room? Okay, great. Well, and I may have missed someone, but definitely it takes all of us. And so tonight, as we kind of look at the Wizard of Oz paradox and how do we become better advocates, how do we help our clinicians to become better advocates, we're going to cover off on a few quick topics. So if we can go ahead and advance the next slide. If you're not familiar with Allergy and Asthma Network, we've been around since 1985. Grassroots patient advocacy, patient education organization, now comprised of about 2 million members across North America. And 90% of those are patients and families, just like my own. I'm the mom of 5 between the ages of 14 and 20. 1 boy, 4 girls, crazy household. And we all have allergies, asthma, atopic disease. And so this is kind of what we live and breathe every day. The organization has been around for a long time. I've been leading for about 6.5 years and have been in the industry in this space of allergy and asthma for 20 years. And we really work to end the needless death and suffering due to allergies, asthma-related conditions through outreach, education, advocacy, and research. And so we're going to cover off a little bit on a few of those topics, but really spend the majority of our time talking about advocacy this evening. Next slide, please. So, how many of you love The Wizard of Oz? It's a great movie, right? How many of you young ones, Finn, have you seen The Wizard of Oz? Do you know about Dorothy? Yeah? All right, we're going to talk about Dorothy a little bit tonight. So, the theme of the Wizard of Oz, what is it? Follow the yellow brick road. Follow the yellow brick road, right? So tonight we're going to go through following the yellow brick road to becoming better advocates and helping our providers to become better advocates. So I'm going to incorporate some quotes. This is one of the quotes from Dorothy. She says, "If we walk far enough, we shall sometime come to some place." And I would suggest that in healthcare, in 2019, we have come to a place of what I like to call healthcare 911. Healthcare has certainly taken a lot of twists and a lot of turns over the last decade. Next, please. So in the past 10 years, and I'm sorry, could you maybe, the projector is a little off. I'm sorry, this is my OCD kicking in at this moment. In the past 10 years, there's been a lot going on in healthcare, and a lot of this change actually has been to the detriment of the provider-physician relationship. I like to characterize it by calling it the 7 deadly sins of healthcare in the 21st century. So the first one is the EMR, or the EHR, the electronic health record. How many of you just love your EMR? You think it's great that your provider's staring at a computer instead of talking to you, right? I don't know a single person who loves the EMR, who's like, yes, this is the best thing ever. Yes, it's delivering exactly what it was told to do. Actually, you know what, there's a study. Physicians are now 63% less efficient due to the EMR. 63%. They're spending twice as much time behind the computer screen as they are face-to-face with you as the patient. So this is a real challenge at this point in time, especially for us as patients. We're trying to train our clinicians on understanding our disease and responding to our disease as an individual. Secondly, is the administrative power that has taken hold in healthcare. So 10 years ago, how many of you were in single private practices? Charlotte has always been big systems, but today, the single hang your shingle doc is basically non-existent. I mean, really, you're looking at a unicorn in Dr. O'Connor as far as a private practice physician in very large systems. And so the administrative power has shifted from what was once a very well-respected profession to now administrative power. There are more business people, more MBAs, and I'm one, so I can say this, more suits, actually making healthcare decisions and driving healthcare systems than physicians. And that's a challenge. That's a real difference in our healthcare system in the 21st century. The next 7 deadly sins, go back please. The next of the 7 deadly sins is ICD-10. So how many of you made the shift to ICD-10, right? Everybody in the room's made that shift. So who knows how many codes we had in ICD-9 versus ICD-10? This is the way that doctors get paid. There were 13,000 in ICD-9, 164,000 in ICD-10. So the complexity of coding just took a whole nother level. Yeah, there's a code for the second time you get set into a jet engine fuselage, because that's likely to happen. Yeah, it's kind of crazy. The next, the 7 deadly sins is physician burnout. And why should we be surprised, right? Because physicians are working twice as hard for much less pay in many situations. There are recent statistics that say 55% of your providers are burnout. Did you know that over 400 physicians commit suicide every year in the US? It's one of the highest rates of suicide in 2018. Is among physicians. And so this is really disturbing to me as a patient advocate, because all these changes are taking place, and it's so challenging for our providers to become the clinicians and the health advocates that we need them to be for us. The next of the 7 deadly sins, the Sunshine Act. So those of you who are in industry, I thought about you when I put this up there, right? Because we have to report everything. If you're eating tonight, we have to report it. If you have a beverage, we have to report it. If you take a pen, we have to, it's just crazy, right? And it was intended to drive transparency in healthcare, but it's gone far, far, far to an extreme. And the truth is, patients don't look at that, and patients don't care. And you know what I tell patients? If you're looking for an expert, you should go to that Sunshine list and find the person who's at the top, because they're the person who's the expert that the industry is willing to pay. So that's who I want pursuing my care, is the person that is the expert, that is getting oftentimes compensated for their expertise. Then we've got the malpractice litigation. And again, I know there's a few lawyers in the room, not to offend them, but the truth is that in healthcare, malpractice is a big concern. And that's why every time we see a direct-to-consumer commercial on TV, Half the commercial is about whatever the condition is, and half the commercial is about all the little minor the side effect profiles that could happen. So that all these things are really impacting the care that patients are receiving and the way in which they interact with their clinicians. And then finally is utilization management, and we've already heard about this with the prior authorization. On average, how many hours a week do you think the average physician, how many hours do you think their office spends on PAs? Prior authorizations, getting things approved through the insurance company. 20 hours per week per provider. 20 hours per week per provider. So insurance companies, there's always a third person in the room at this point. It's not just you as a patient and your healthcare professional. There's an invisible person in the room. Did you know that? It's the payer. And they're dictating more of your care than even you or your provider. They're undermining that care in many cases. And so again, we're advocating to change a lot of that. Next slide, please. So my next Wizard of Oz slide, Dorothy clapped the heels of her shoes together 3 times, saying, "Take me home to Aunt Em." You remember that in the movie where Dorothy clapped her shoes together and there's no place like home, there's no place like home. So can we go back? Is there any way to get out of this hole that we found ourselves in 2019 with healthcare? I'm not sure. I really think that the train has left the station. And then unfortunately, we've got to find a better way. We have to address some of the systemic issues that are going on in healthcare, and we really need to have a conversation that is empowered by patients and providers driving the conversation rather than just being dictated by politicians and payers. Next slide. So, what can we do? We can encourage our clinicians, first of all. You already heard this. It's important for us as patients to get the proper exercise and diet, to take vitamins, to hydrate, all those different things. But this is important for our clinicians as well. Like, I work with a lot of doctors across the country. Every allergist and immunologist in the country is part of the network. And I see this. I see them breaking down and not restoring, replenishing, and rejuvenating. And so we need to encourage them. And the reason why people went into medicine, the reason they stay in medicine, is because of the patients. And I know it's hard as you're a patient, you're sitting there, you've been waiting, and you're waiting and waiting, and then the doctor comes in the room, and you feel rushed, and you feel like they're not paying attention because of the EMR or what have you. But it's really important to recognize that that provider is a person. And they're a person just like you, going through all these things that are real life struggles for us as well. And I think we have to just stop and end the silent struggle and kind of share and take care of our own in the community. I think it's time that we talk about things like mental health issues and physician burnout and suicide. I mean, these are really critical, important issues in healthcare today. And this is my quote, this is not a Wizard of Oz quote, but I've started saying this because, it is illegal for physicians to unionize in the US. Actually, providers can't do that. It's illegal, but we can galvanize. And now is the time as a community, as a healthcare community, that we have to come together and galvanize to really effect change. Next. So, next Wizard of Oz slide. You have plenty of courage, I'm sure, answered Oz. All you need is confidence in yourself. There is no living thing that is not afraid when it faces danger. When we face danger, we're afraid. The true courage is in facing danger when you are afraid, and that kind of courage you have aplenty. Each one of us has that courage in us. If we just really stop and tap into it, we can find the courage to stand up in the face of these times and really make a difference. Next. So, One of the quotes was, Toto did not really care whether he was in Kansas or in the land of Oz as long as he was with Dorothy, right? Toto was always happy. His tail was always wagging. Why? Because he was with Dorothy. And it's the same thing as you're a patient and you're going through this journey of living with primary immune deficiency or any other immunological or chronic disease. You need a strong support system. You need to have a strong patient-provider relationship. And you need a strong support system around you. Next. So these are some of the barriers to effective communication. We're short on time. You guys know this, right? There are all sorts of reasons why we fail to communicate in the context of our health. And Dr. Watson, how are you doing? What do we say? Fine. What does that mean? What does that mean? It means that I'm actually breathing at this moment, that I'm not killed over in the floor, but it doesn't really reflect how we're doing as individuals oftentimes. Rarely do we ask about the psychosocial impact of a disease. Rarely do we ask about the mental health issues of a disease. Rarely do we ask how it's impacting your family life and the social support system, your job. Who has time for that, right? So there are a lot of different barriers to really good communication. Next slide. This often leads to non-adherence, which I laugh because all that means is that some doctor told a patient that this is what they should do, and the patient goes home and says, I'm not doing that. I'm doing exactly what I want to do. They didn't have a shared goal. They had the physician's goals of treatment, and the patient walked out not on the same page. Right? I'm going to bet that every single one of us in this room has at some point in time been a non-adherent, non-compliant patient. How many of you have ever had a course of antibiotics that you didn't take all of them? Guilty. How many of you have ever been prescribed a daily medication that you happen to skip once or twice a week? Guilty. How many of you have had that conversation with your doctor who says, I think you need to lose about 10 to 20 pounds? Guilty. Right? Or how about that exercise 3 to 5 times a week? Guilty. So the truth be told, we're all non-compliant, non-adherent patients. So these are some of the variables and reasons why that happens. And it's important to know that so you can help your clinician be a better clinician and you can have an honest conversation. You can be upfront and say, Doc, I know that you prescribe this every day. I'm not doing that. And here's why. Have any of you ever had that conversation? Yeah, I have. I've had it with my teenager who refused to take her controller medication for asthma. And I said, "What? You have to breathe. What do we not understand here? And so it changes the conversation when you're able to have those honest dialogues back and forth about why adherence isn't optimal. And really normalizing non-adherence, because the truth is we're all non-adherent. Next. So this is some of the disparity kind of around asthma and physician data. And I don't want to spend any time because I know that, again, I'm between you and the entertainment of the night. But the bottom line is physician, patient, the greater the racial barriers, the greater the socioeconomic barriers, all of those things that come into play just cause greater and greater gaps. And in asthma, in PID, in COPD, in any kind of chronic disease, we see these gaps between persons of color, persons of lower socioeconomic status, and those of us who are Caucasian and more educated and all of those things. And that's the reality. And so we have to do a better job at addressing these gaps and building that communication to address the disparities in care. Next. So there's this concept called shared decision making. And of all the providers in the room, how many of you use shared decision making? Most people are going to raise their hand, right? And when I talk to providers, actually about 95% of them say, yeah, I do that. I do shared decision making. And there was a recent study actually in the New England Journal of Medicine. On the next slide, it kind of gives the details of that study. If you'll advance that, please. And so a study of 1,000 different clinical encounters between physicians and patients, over 3,500 decisions within that 1,000 encounters. And again, when the doctors asked, are you doing this? Greater than 90% said, yep, I'm doing it. And these are the 4 things. Did the patient understand the nature of the decision? Did they play a role in making the decision? Did you explain the pros and cons of the decision? And was there discussion around the individual patient preferences and values for the decision? So 90% of doctors, yep, I do that. Guess when they actually objectively observed those clinical encounters, guess what percentage actually met the 4 criteria? Anybody? 30, I heard. That's optimistic. 25. Ben says 59. You are very favorable to the physicians. You really believe that doctors are good people, don't you? All right, let's see what the actual number was. 9%. 9% were doing true shared decision making with those 4 components. So we have a lot of room to improve when it comes to shared decision making. And why is that? Why is it that there's this gap between physicians and patients when it comes to shared decision making? The next slide, please. So there are 6 steps, and oftentimes it's because physicians don't fully understand these 6 steps of, inviting the patient to participate. And with a lot of patients, you have to do that. You actually have to say, I want you to help me make this decision. This isn't just my treatment plan. This is our treatment plan. And how are we going to go about that together? Presenting the options, because guess what? We've already talked about it. Doing nothing, it's an option. Now, it may not be the option that you would choose as their provider, but it may very well be the option that the patient prefers. So it's discussing that and eliciting those discussions. Then providing information on the benefits and risk of each of those options, and then having those patient preference discussions. What matters most to you as a patient? Because I'm going to tell you, what matters most to my 15-year-old in managing her asthma is completely different than what my personal preference is for her. Completely different. We have totally different treatment goals. It's really interesting. So that can be hard, right? Because she's more worried about not being embarrassed by being different in front of her friends. I'm more impressed by the fact that she's at school, not in the ER, able to do the things she wants to do. But for her, it's all about that social pressure of being different and using that inhaler in front of everyone. So we've had to come up with different strategies based off of her treatment preferences and her treatment goals versus my own. And then facilitating deliberation within the family, because sometimes there's decisions that can't be made at that time, right? And especially when you're talking about the treatments like Lauren was talking about, where you're going in every 3 weeks and getting injections or infusions, and it's a very complicated treatment plan. That takes a lot of commitment, right? And so you have to have that full-on discussion about this. And then assisting the patient with implementation. So there's a lot of steps to shared decision-making. Next. The truth is, it's not a one and done. It's not like, okay, we did that, check the box, we can move on. At every single opportunity, every single visit, we have to have that conversation around making those decisions and initiating that process. And again, the truth is, this is good for everybody. It's a win-win-win for patients. It's a win for the provider because it actually decreases your malpractice rates and it gets greater adherence. So it's a win for the patient, it's a win for the provider, it's a win for industry, it's a win for everybody in this room who cares about really good patient outcomes. Next. So why aren't we doing it? Again, there's a lot of barriers, and the bottom line is, as we said before, we know that there's things we should be doing, but sometimes we just don't do it. Sometimes we're lazy. Sometimes we think we're doing it, we're actually not, and so this is a great cartoon. It says, the best thing you can do is give up smoking, drinking, and fried food. The patient says, what's the second best? So, yeah, that's the truth. We're not always willing to make the sacrifices that need to be made to get the best health outcome. And we just have to be honest about that and figure out how to move forward from there. Next slide. So again, we're moving from this paternalistic, physician type of scenario to more of an informed choice. And it really isn't, you don't want your patients out there just on, WebMD, Dr. Google, making their own healthcare decisions independently. It needs to be shared. So we can't have any one of the two extremes. We need to come to the middle. It's the best scientific evidence along with those patient preferences and marrying those two things together to come to what's the best treatment option for that patient at that time. Next slide. All right, another quote. Experience is the only thing that brings knowledge, and the longer you're on earth, the more experience you are sure to get. Boy, do I use this quote and theme with my 5 teenagers often, because they think that they know everything, right? I'm like the dumbest person on earth right now, according to my 5 teenagers. But it's amazing because I often go back to the time in my life where I thought my mother was pretty stupid too. It's amazing how smart she got once I turned 25. And every year since then, she just keeps getting smarter and wiser and wiser and wiser. With Mother's Day coming up, I had to bring that up because it's true, right? The more experience we have in life, the more knowledge, the more perspective. And so definitely that's the case in healthcare as well. Next slide. So how do we take action? These are a lot of the different ways that we work with Dr. Brown in the Center for Chronic Disease Management and Allergy and Asthma Network on health literacy and really just helping patients to understand their healthcare better and how to advocate for themselves and empower themselves. It is a lot about education because education is critical, but it's also about understanding socioeconomic decisions. Let's be real. Sometimes people are choosing between a roof over their kid's head, food on their kid's back, or food on their table or clothes on their back. It's a long day. And so, these are challenges that real people are dealing with every day. And so here you are prescribing a medication or encouraging a patient to take a medication or a treatment that is that choice. And Maslow's hierarchy of needs doesn't lie, right? So people are going to take care of those fundamental needs before we can ever get to that whole self-actualization, top of the pyramid stuff that, empowerment, self-actualization that a lot of people attest to, which again is great. But it's only great if you have the security, the belonging, the breath, the food, the water, all the things that are basic necessities of life. Next. So this is a campaign that we've worked on together, and it's called Asthma Take Control, Take Action, that really is about empowering patients. And then next, please. These are some more of those tools that are in that toolkit specifically, and I won't spend time there because I know we're short on time. Go one more. Again, this is some of the specifics around minimizing the disparities in the clinical setting. And again, I can share the slides after because this is directly from a study that Dr. Brown did on how to actually address underserved communities in the clinical setting and really how to bridge the gap when perhaps that's not the world that you live or have come from. Next slide. So it's time to take action. It's time to advocate. The Scarecrow, one of my favorite characters from The Wizard of Oz. Some people without brains do an awful lot of talking, don't you think? So this is where we're going to bridge to talk about politics for a few minutes and advocacy from a legislative standpoint. That's why I chose this quote. So next slide. What is advocacy? You know, a lot of people think it's lobbying. It's not. Lobbying is a type of advocacy. It's where you're actually pushing for a specific legislation. And we do that some at the network, but it can only be a small portion of the work that we do. More of the work we do is around general advocacy. So it's educating, it's the active process, the act or process of supporting a cause or a proposal. And then public policy is how do we advocate for public policy that does that around a specific issue. And so there is a nuance between advocacy, public policy advocacy, and then also lobbying. Next slide. All right, so the thing is, you can make a difference by really speaking up and number one, exercising your right to vote. That's always critically important. But also just being involved in how laws are made and how laws can be changed and improved. And you have a story to share. And to be honest, your federal decision makers, your state decision makers, your local politicians, they want to hear these stories. You're their constituent. They care, and they really do want to hear from you. Next one. So these are our policy priorities at the network, and you'll see it's a lot around access to care, access to medicine, climate change. The air we breathe is very important for those of us who live with compromised lung health. Definitely in addressing health disparities and ending some of the things that the policies that are negative to create those disparities are all part of our filter of deciding what we're going to be engaged in when it comes to advocacy. Next. So what are we doing right now in advocacy? First of all, we've got a huge event coming up this week. Dr. O'Connor will be up in DC on May the 8th, and we've got a couple of hundred people that'll go out and make about 250 visits with senators and representatives about some of the issues that are facing families living with allergies and asthma. We do that every year. We also have a congressional caucus that we engage on a routine basis and just keep them updated because they're kind of our champions in Congress for all the issues that we're facing. One of the things we're trying to advance is telehealth, and so there's a bill to actually recognize respiratory care services and to make sure that whatever you do in person in a telehealth visit, you could also do, that you do in a personal visit, you could do in a telehealth visit and get the same type of reimbursement for it if you're doing the same work. That's called telehealth parity. And then school-based allergies and asthma, so this is where we're actually advocating for schools to have the quick relief inhalers in schools and to ensure that no students, unfortunately, pass away. Every single year there are students that pass away in schools because they don't have their inhaler with them. And so this is a legislation that would actually allow schools to have that stock. And then the next one is Safe Step Act. This is where, again, a lot of you have probably faced this, where your payer, your commercial insurance payer, is forcing you to fail on a certain treatment before you can escalate to the treatment that's the best one for you. So let's say that Dr. O'Connor and I decide that the best treatment for me is treatment C, and my insurance comes back and says, yeah, no, you get treatment C. Actually, you got to fail on treatment A and B. And then, oh, by the way, if you change insurance, you got to fail on it again, right? So that's called step therapy or fail first policy. And so we're trying to get the law in place. We have a federal legislation now that's been proposed to limit the payer's ability to do that, so that it re-establishes the patient-provider decision-making process and takes that third-party payer out of the room and forces them that if they put that policy in place to give you an answer within 48 hours of the denial and to set a clear appeal process so that you as a patient know how to advocate. We're also advocating for a lot of these policies at the state level. We've had about a dozen state laws in these areas passed this year. And then we're working on cost effectiveness and payer policy changes, because policy to us is federal policy, state policy, and then also payer policy. So we do a lot of work on all three of those levels. Next. So how do you get started if you want to do this? If you want to be an advocate, if you want to begin to affect change in policy, it's knowing what your priorities are, knowing who the targets are, knowing your message in a very concise 1 to 2 minute elevator speech. You're not going to get much time with those federal decision makers or your state decision makers. So having your, soundbite is very critically important. And then, knowing what kind of resources you need. I always say it's about 3 things. When I'm talking to a policymaker, it's about 3 things. Number 1, it's about emotion. They want to hear your story. They want the heart. You got to pull at the heart first. If you get the heart, then you got to go to the head. And it's about the evidence. So, emotion, evidence, then you got to go to the back pocket. It's about economics. So policymakers want to know about those 3 things: emotion, evidence, economics. And if you can make that pitch to them about a policy in a matter of 3 to 5 minutes, you're off to the races. That's how we have 3 federal bills actively moving through Congress today. It's because we know how to frame the message. Next. If you don't know who your elected officials are, there's a very easy way to do that, and it's here in the deck. But you can go to this website, put in your zip code, and it tells you exactly all their contact information, how to get in touch with them, and how to engage. Next. And then there's a variety of different ways. The most effective way is an in-person meeting. Definitely, if you make the effort to come to DC or to go to the district office, it's the best. But also, they have to log every letter, email, phone call. And so, there are these staffers that are in DC sitting in every office, and that's all they do all day long, is log who calls and who reports on what issue. And then they advise the member how to vote on the various policies. That's the way that the system works today. And that's the way that our federal decision makers specifically make a lot of their decisions. Next. So this kind of gives you about the details of how to advocate in person. Again, I'll make these slides available if anybody's interested in those details, but I think it's very important, that you go in with a specific action. It's great to come in and to tell your story, but if you don't have an ask, and I mean an ask that they can walk out of there and act on today or tomorrow, there's going to be 10 other people coming through there in the next 5 or 6 hours. So, that's just the nature. In any given day, our federal decision makers are talking about healthcare, they're talking about energy policy, they're talking about, economic policy. I mean, there's so many different topics that they could be covering. So you have to have that very clear ask. Next. And you can advocate other than just one-on-one with those people. It's a whole new world with social media and politicians, as we know, with our current administration. And so, you can use social media, you can use a blog, you can use public testimony, you can use traditional media. There are many different ways to engage and to get your voice heard. Next. So the bottom line is, be an advocate. Your voice matters, it makes a difference, but we can't sit back and keep complaining about how bad healthcare is. Not as clinicians, not as patients, not as industry. We don't have that right. We have to come to the table and find a way to actually make a difference and make a change. And that's kind of, I think, the last quote. Next slide. Follow the yellow brick road. How are we going to get there? And this is a quote that I came up with, and I really keep at the forefront of the work that we do at the network. Each of us has the opportunity to make a difference. Every day, each one of us has that opportunity to truly make a difference. Whether it's the patient that's sitting in front of us at that moment, whether it's the PA that we're fighting for, the prior authorization that we're fighting for to get that patient the medication they so desperately need. But the truth is, the only way we can make sustainable change is together. We can make a difference one-on-one. But to make a sustainable, significant change, it takes all of us coming together to do that. And so I think that's one of the most powerful themes of The Wizard of Oz, and hopefully that message has come across tonight. Thank you for the opportunity to be here.